Good afternoon, everybody. My name is Dr. Wayne Terrace, and I am the Chief Medical Officer at Care Compass Network. Welcome to the first annual Partnering for a Resilient Community virtual learning. This fireside chat on ACEs in the clinical setting with Dr. Brown webinar is sponsored and supported by the Care Compass Network's Regional Trauma-Informed Care Network team. The team consists of dedicated and passionate individuals from colleges, county government, healthcare, social care, human services, and schools spanning across Care Compass Network's 9-county region in the Southern Tier and beyond. The Regional Trauma-Informed Care mission is to implement evidence-based trauma-informed care by supporting the development of resilient and strong partnerships, individuals, families, and communities through advocacy, education, and empowerment. A core strategy to bring this to fruition is to create and promote access, availability of training, educational tools, and resources for our community. Before we get started with this presentation, I would like to go over just a few housekeeping items. Today's presentation will be recorded for quality assurance purposes and may be uploaded to CCN's website or YouTube page. We are going to reserve the last 10 minutes for questions and answers. Please type your questions into the question and answer box, which is located on the bottom of your screen, and you can send in your questions at any time during the presentation. We will be collecting these and addressing as many of them as possible after the presentation. And now I would like to introduce our presenter. Dr. Nicole M. Brown, MD, MPH, MHS, is a general pediatrician and health services researcher and is the founder and chief health officer of Strong Children's Wellness, a new pediatric primary care practice that reverse integrates comprehensive pediatric care into existing child and family serving behavioral health and social services organizations. Dr. Brown formerly served as assistant professor in the Division of Academic General Pediatrics at the Children's Hospital at Montefiore, Albert Einstein College of Medicine. Her research and professional interests center on enhancing care and service coordination for children who have experienced trauma and those with chronic mental health needs in the pediatric primary care setting. Dr. Brown completed medical school at Stanford University School of Medicine and her pediatric internship and residency at Johns Hopkins Hospital. She obtained a master's in health sciences as a Robert Wood Johnson Foundation clinical scholar at the Yale School of Medicine. So with that, Dr. Brown, I will hand it off to you.
Thank you so much, Dr. Terrace, for that introduction. And I'm so happy to be here to talk to you today about the science behind ACEs and my experiences screening for ACEs in the primary care setting. I have nothing to disclose. So today's talk, just to give you an overview, I'm going to start by briefly reviewing the science behind adversity and adverse childhood experiences, or ACEs. And I'll do that by taking a population level lens and also looking at the individual level to really understand how ACEs get under the skin and cause downstream issues with health. And then I'll move into screening for ACEs in clinical settings. We'll talk about the risks of screening versus the benefits of screening, as well as talk about sort of conventional ACEs. And there's now this move toward expanding our definition of what adverse childhood experiences are. So I'll talk a bit about that. And then finally, I'll end with a discussion of trauma-informed care and talk a bit about interventions to help to mitigate adversity and hopefully build resilience. So let's just start with a definition of ACEs. And I think it's important that we're sort of all speaking the same language here. So a few definitions out there, but one that's generally used is from the Substance Abuse and Mental Health Services Administration, and they define ACEs as stressful or traumatic events, including abuse, neglect, and household dysfunction, occurring before the age of 18 years that have adverse effects on individual functioning and physical, social, and emotional well-being. And, I was actually struck by sort of how the story of ACEs began, the history behind the original ACEs study. And for those in the audience who don't know, it began with an internist and a gastroenterologist, Dr. Vincent Felitti, who was at the time working at Kaiser Permanente Medical Center in San Diego. And he ran a large obesity clinic that was actually pretty successful at getting people to lose weight. And despite his success, in the mid-1980s, he was seeing a high dropout rate in his clinic, and he couldn't understand why, because the folks that were dropping out were actually losing weight and doing pretty well. And so he decided to interview a sample of these dropouts. And during the interview, he asked a question, and instead of asking, how old were you when you first became sexually active, he asked, how much did you weigh when you first became sexually active? And this was sort of, an accident. And the patient said, the woman answered, 40 pounds. And if you sort of know how old someone is when they're 40 pounds, the rule, as a pediatrician at 4 years old, you weigh 40 pounds, this woman disclosed that she had been sexually abused by a close relative starting at the age of around 4. And that's when Dr. Felitti struck on something, and he began to interview both qualitatively and quantitatively more of his patients. And he was struck, of the 286 patients that he interviewed, he was shocked to find that a significant proportion disclosed that they were actually sexually abused in childhood. And so that led to what we now know as the seminal ACEs study. And Dr. Felitti partnered with the Centers for Disease Control, the CDC, and together they surveyed over 17,000 adult patients at Kaiser Permanente. Their objective was to understand the relationship between child adversity and adult health outcomes. And so they devised a 10-item questionnaire that covered 3 domains of childhood exposure to adversity. They were abuse, so this included psychological abuse, physical abuse, and sexual abuse, household dysfunction, and this included exposure to a parent or caregiver with substance abuse issues, mental illness, domestic violence, criminal behavior or incarceration of a caregiver, or parental divorce. And then finally, the 3rd domain was neglect. And this included a question on emotional neglect and physical neglect. Each positive response was given a score of 1, so that someone's ACE score could range from 0 up to a total score of 10. And what they found was pretty striking. They found that of those 17,000 adults that they queried, more than 50% reported at least one adverse childhood experience. More than 25% reported 2 or more ACEs. And when they looked in other studies at the relationship between ACE score, some common risk behaviors, and the common chronic diseases that we see in adults in this country, they found what's called a dose-response relationship between someone's ACE score and their risk of having a specific illness or a disease. And so, for example, they found that compared to someone with an ACE score of 0, someone who reported an ACE score of 4 or more were more likely to have a 5-fold risk of 2 or more weeks of depressed mood in the past year, and were more than 12 times more likely to have ever attempted suicide if you had 4 or more ACEs compared to if you reported no ACEs. They found the same thing, the same dose-response relationship when looking at some of the common chronic physical health issues that we see in adults. So for ischemic heart disease and stroke, for an adult who reported exposure to 4 or more ACEs in childhood, they had more than a 2-fold risk of having these conditions compared to someone who reported no ACEs. And for chronic bronchitis and emphysema, significant risk as well if you reported 4 or more ACEs compared to none. So I'm a pediatrician, so a lot of what you're going to hear throughout this talk is from that lens. But you know, when we look at the data behind ACEs exposure in children, we see similar patterns. So in a study that was done in 2014 that took a national sample of children in this country and asked their parents about exposure to some of these adversities, they found that 48% of children in this country report being exposed to 1 or more ACEs, 23% 2 or more ACEs. And when you look at the distribution of ACE types that children are exposed to nationally in this country, you see that poverty, it's termed economic hardship here, that's the most common ACE reported with just over 25%, followed by parental divorce, substance abuse, neighborhood violence, that neighborhood should say neighborhood violence, parental mental illness, domestic violence, parental incarceration or incarceration of a caregiver, and racial and ethnic discrimination, and then finally death of a parent. We also see that ACEs in children are associated with poor child health outcomes at the population level. So a number of studies have sort of replicated this over and over again. And we find that exposure to childhood adversity and a high ACE score is associated with worse asthma, with headaches, with developmental delays, with poor academic performance in children, with ADHD, and I highlighted that because that's something that I'm passionate about exploring and is a research focus of mine, and on adolescent pregnancy. In the figure at the right, this data is from a study that I did with some colleagues in 2017, which looked at a national sample of children and asked the question, are ACEs actually associated with having an ADHD diagnosis and worse ADHD outcomes? And indeed, what we found is that children who are exposed to each type of ACE that I reviewed in the previous slide have a much higher prevalence of having an ADHD diagnosis, which is represented by the blue bars, compared to those who don't have ADHD, which is represented by the red bars. And when we looked at the different types of ACEs and their association with a parent reporting that their child had moderate to severe ADHD, we found that children who live in poverty and those exposed to a family member with a mental illness had a much higher odds of reporting moderate to severe ADHD. And we found that same sort of dose-response relationship between ACE score. That is, as you go up in ACE score, your risk of having moderate to severe ADHD also goes up. Not only are ACEs associated with poor health outcomes, but they're also associated with suboptimal use of the healthcare system and poorer access to care. So in a study done in 2017 by Alcala and colleagues, they found that every single one of the 10 ACE types that the CDC queries about are associated with a lower odds of being insured in this country, in a national sample of US adults. And they also found that emotional abuse, familial mental illness, living with a drug user, familial incarceration, and having a parent divorce was associated with lower odds of having a personal doctor. They found that sexual abuse was associated with having a lower odds of a yearly checkup. So ACEs, exposure to ACEs not only affects health, but it also affects how we use the healthcare system, and has been associated with suboptimal use, which of course leads to worse health in the long term. So despite, the public health significance of ACEs and the evidence that shows how strongly associated they are with poor health outcomes, it's important to note some limitations behind some of this population level ACEs data. First off, not all traumas are created equal. So, in the ACEs questionnaire, as I mentioned, each ACE is given the same score of 1. But we know that not all adversities are equally traumatic. A death of a parent may be felt much differently than a divorce, for example, for an individual. And there's just a wide variation in someone's stress response and differential experience of trauma that's not really taken into account in a lot of these population level ACEs studies. Much of the data that we have about ACEs is what we call cross-sectional. So it's sort of a snapshot in time. And we need more studies that look at the timing of when these ACE exposures occurred, the duration of these adversities, and whether people are actually experiencing them as trauma. We need more long-term longitudinal studies that show us whether there's actually ACEs may actually cause these things and go beyond just seeing whether ACEs are associated with these outcomes. And then finally, the conventional ACEs questionnaire was asked in a pretty homogeneous sample of, the original study conducted by Dr. Felitti and colleagues was done in largely white, a wealthier white population. And so the concern is that some of the ACEs that were captured may not necessarily capture some of the unique adversities that other communities may experience, such as racial and ethnic discrimination, or other immigration-related stressors and other social injustices. So I wanted to just pause here and ask a question of the audience. So this is a poll question, and I give you guys a minute to respond. But the question is, how do ACEs get under the skin to cause poor mental and physical health? So first response can be accumulation of ACEs can cause changes in the brain architecture, leading to developmental and behavioral disorders. The duration, severity, and number of ACEs can cause toxic levels of stress, leading to inflammation and lowering the immune response. We don't really know how ACEs get under the skin to cause health problems. Research is still ongoing, or both A and B. So I'll give you guys a few seconds to respond. Great. So it looks like the majority of you answered both A and B, which is correct. And we actually know a good deal about adversity and the stress response at an individual level. So let's just briefly review what the science behind what we know happens. So we know that when confronted with adversity, adrenaline is released, and that triggers what we commonly term the fight or flight response. Your hypothalamic pituitary adrenal axis releases a hormone called cortisol. And cortisol is actually a good thing in that during the fight or flight response, it helps to mobilize your body's energy stores, it activates your immune system, and it actually briefly enhances memory. And, when these stress response systems are activated in children, for example, in the context of supportive adult relationships, this physiology that I just described is actually protected and buffered. But what happens when you don't have those buffering relationships and your body is constantly in fight or flight mode, and you have this constant elevation of cortisol and other hormones, is you actually experience what's known as toxic levels of stress. And this can cause traumatic alterations throughout the body, including changes at the genetic level, changes in the architecture of the brain. And those changes in the brain can lead to what we call maladaptive behavioral responses. So ADHD, developmental delays in children, and then also poor downstream physiologic responses like a lowered immune system that increases risk for cancer and other end organ damage. In the brain, toxic levels of stress hormones can actually rewire brain connections and in extreme cases cause death of the cells in the brain called neurons. And this occurs especially in areas of the brain called the prefrontal cortex and the limbic system. And the limbic system consists of the hippocampus, which is largely responsible for learning and memory, and the amygdala, which is responsible for how we regulate our emotions and emotional reactivity, and is also sort of the seat of that fight or flight response that I described. And the prefrontal cortex is responsible for executive functioning, so how we organize, how we plan. It's also responsible for attention and self-regulation. I don't know how many of you are familiar with the science behind dandelions and orchids, but I thought it would be important to sort of note here in that, it's just important again to remember that we all experience stress differently, and there's individual variation in excessive stress activation. So some people are like orchids. They're exquisitely sensitive to changes in the body as a result of stress, while other people are like dandelions. They are, if any of you, most of you know, dandelions are pretty hardy flowers, hard to get rid of them as much as you might try. And despite exposure to severe stress, dandelion people are pretty resilient. So there's a lot to learn about both orchids and about dandelions. What is it about those folks who, despite being exposed to tremendous adversity, are able to overcome, are able to even thrive and be resilient? So I sort of reviewed, gave a brief overview of the science behind adversity, ACEs, toxic stress, and its downstream effects on health, mental health, and healthcare use. And given all of that science, the American Academy of Pediatrics in 2012 came out with a policy statement that essentially said, given sort of the public health importance of ACEs, pediatric practices and other primary care settings really should strongly consider implementing standardized measures to identify family and community level factors that put children at risk for toxic stress. So I'm going to now talk about ACEs screening, or systematic identification of ACEs in clinical settings. And I think when we're talking about screening, we really, especially screening for sensitive issues like exposure to childhood adversity, there's some really important things to consider. One is, when you think about screening for anything, whether it's, diabetes or heart disease or ACEs, screening really has benefits when we have interventions in place that can mitigate the potential harmful outcomes of a positive screen. So with ACEs, there's no one size fits all intervention. There's a wide range of potential interventions needed for specific ACE types. And the costs of and skill of developing, a really kind of diverse, heterogeneous workforce to be able to help someone with a positive ACEs screen might actually be cost prohibitive in certain settings. So that's important to consider. The other thing is that, most people sort of assume that if you have a high ACE score, you automatically need to see a mental health provider of some sort. And, I introduced the Dandelion and Orchids concept just again to illustrate the point that not everybody experiences those ACE exposures. They happen sort of in childhood. Not everyone is experiencing it as a current trauma that necessitates treatment right now. And, the science actually behind referring to behavioral health for someone with a high ACE score is actually limited. We need more information about that. Although the studies that are out right now show tremendous benefit for certain populations of people who have had high ACE exposures. The ACEs questions are pretty sensitive questions. And for someone who shows up for their physical, their annual wellness exam, and you hand them an ACEs screen and they're not expecting that, they may see those questions as very intrusive. Some of those questions carry a lot of stigma. And then there's a risk for overtreatment, again, because everyone who screens positive may not be experiencing traumatic stress. And so if you sort of automatically funnel those high scorers to an intervention that they may not need, that risks what we call overtreatment. Underreporting of ACEs is an issue, and we'll talk about that in a minute when I kind of share my own experiences with ACEs screening. But in pediatric settings, a lot of parents, again, some of these questions carry a lot of stigma. Some parents wonder, why are they asking me this? Are they gonna call child welfare, if I answer positively? So some of these questions may provoke, parents may be concerned that they provoke suspicion of abuse. And then finally, the usefulness of a screening tool depends on its accuracy, what we call its sensitivity and its specificity, and the potential to inform how we make clinical decisions. And you want that screening tool to enhance the receipt of good care and to promote health. There's still a lot that needs to be done in the ACEs science around sort of screening or measuring the ACEs screen sensitivity and specificity for actually picking up traumatic stress and current trauma. So in pediatrics, we screen a lot. And you know, for those of you in the audience who work with children, you know this. You know, we screen the new mom for depression using a PHQ-2 or an Edinburgh. We screen the 24-month-old for developmental delays using an ASQ. We screen an 18-month-old for autism using the MCHAT, and on and on. We screen the school-age child for ADHD using Vanderbilt's. Psychosocial difficulties for school-age children, we use a tool, a widely used tool called the PSC-17. So there's a lot of screening that goes on in pediatrics to pick up potential concerns early. And the question is, you know, for ACEs screens, how accurately do ACEs actually capture stress exposure in children? And do we have interventions in place for downstream effects? So I talked about the risks of screening, and I just kind of want to go through the benefits of ACEs screening. So one benefit is that, you know, screening for ACEs really helps to give you sort of context about, you know, what the child or that parent or adult has dealt with in their lives. And it really opens the door for further conversation. And it can help at a population level. It can help you risk stratify populations. So, you know, someone who screens positive on the ACEs and has a high ACE score might be put in a higher risk category because you know that they're at much higher risk of having downstream negative health effects. So you want to sort of monitor that individual a little bit more closely if you're a clinician. ACEs screens can also help inform referrals. I mentioned behavioral health. So, you know, once you screen someone, if you determine that they've scored, they have a positive ACEs screen, and they're also having a concurrent mental health issue, it helps inform referral to behavioral health services, for example. If you're screening parents of young children and they've been exposed to ACEs, you know, as a provider, you really want to prevent ACEs from accumulating for that child. And so you might refer to a parenting support program. You know, ACEs, again, it opens the door for conversations about whether someone's experiencing stress, traumatic stress, or other stress related to a specific ACE type. So you might want to refer to a stress reduction program. So ACEs screening, the results of it can really help to inform referrals. And finally, at the population level, if you screen sort of a large population, which we did in my previous institution, it can help you kind of monitor different aspects of the health of that population and potentially help influence policy decisions. It also can help prompt systems to be created to allow for closer surveillance of developmental and health outcomes and further refinement of specific interventions to better target traumatic stress and to sort of ensure that you have trauma-informed interventions in place. So I'm going to ask another poll question. This question asks, what is the best approach to screen for ACEs in clinical settings? And some of you may not have ever done this, but take your best guess. So first potential response, there is no one-size-fits-all approach. Implementing ACEs screening depends on available resources, practice and institutional buy-in, and other factors. Second, give every patient a screener. Tell them this is a new initiative and that it's important for them to complete the screen. And then finally, the risks associated with ACEs screening outweigh the benefits, and it's probably best not to screen. I'll give you a few seconds to respond. Excellent. So most of you answered to that first, most of you answered A, which is correct. And I'll sort of go into why. So there is no one size fits all approach to ACEs screening. And it really, really, if this is something that, you know, if you're a clinician, a provider, and this is something you want to embark on, you really need to kind of consider the culture of sort of where you're practicing, get buy-in not only among your colleagues and among ancillary staff in your practice and among your patients, but also at the institutional level, at the higher, you know, among the higher ups at your institution as well. As Dr. Terrace mentioned in my intro, I previously was at Montefiore Medical Center in the Bronx. I served as a pediatrician there for over 6 years. And in 2016, we decided to embark on universally screening for ACEs across our pediatric primary care practices and some of the family medicine practices as well. And this wasn't an easy sort of effort at all. We really, when we introduced it, you know, there was a lot of concern about some of the issues that I raised in previous slides. You know, what would parents think if we handed them the screen when they were showing up for, you know, a concern for their kid's ear infection and we're giving them an ACEs screen? You know, what are they going to think? Some of our nurses had a lot of reservations because we were sort of asking them to give the screens at triage. Many people, you know, disclosed they were actually triggered by the screen, but they had trauma histories that they sort of privately disclosed and said that just reading those questions was triggering to them. And so there was just a lot of, well over a year of really intense discussion, meetings, and kind of really just getting buy-in from people in my practice. And then as the initiative grew in other practices around universally screening. But we came to consensus and adapted the CDC ACEs screener, which we gave for both infants and parents. So we adapted the screener so that the questions were asked not only of the parent and their ACEs history, but also of the child. We did screening starting at the 2-month well visit. And then we, for infants, or for children, I'm sorry, we did child ACEs screening at each yearly well visit, starting at age 12 months through adolescence. So family got an ACEs screen essentially every year they came in for a well visit. And then for the infants, they got it at 2 months, and in some places, again, at the 4-month visit, and then not again until the 12-month visit. And so we attached a cover letter to the ACEs screen that, you know, really was meant to emphasize why we were even doing this. And one of the things that we wanted to emphasize was the association between ACEs and long-term physical health problems, such as diabetes, high blood pressure, heart disease. So I'll leave this up for a second so you can sort of read the letter that we attached. But we also emphasize that, even though these are personal questions, it's important to answer this questionnaire honestly, because at Montefiore, we have the opportunity to identify these risks so that we can help prevent or lower the risk of health problems to your child. And then we wanted to emphasize the confidentiality of the answers, and that answering the questionnaire is completely optional. So every parent got this cover letter attached to the ACEs screen, and they typically would complete it when they were alone with the nurse during triage. The nurse would hand it to them. And so after the nurse gave the ACEs questionnaire with the cover letter attached, the parent would complete the questionnaire. But it's important to note that we collectively made the decision to only collect someone's ACE score. So all the parent had to do was count up the number of ACEs that they were exposed or the child was exposed to and write the number down. They didn't have to circle which ACE. And we did that as a way to, hopefully mitigate the stigma associated with answering yes to certain ACEs questions. The nurse then entered the ACEs score into our medical record system, which was EPIC, for the provider to review. So what would come across my desk and all of the pediatric providers' desks was the person's ACE score. And if the score was between 1 and 3, again, as I mentioned, ACEs, a positive screen really sort of opens the doorway for a conversation. I sort of would emphasize again the relationship between ACEs and downstream health effects, and that my role as a pediatrician in partnership with some of the other team members we had in my practice is really to kind of help prevent ACEs from accumulating and to get help if needed, to get the parent or the child help if needed. So ACEs scores between 1 to 3 would necessitate provider counseling. And then a score of 4 or higher, we would refer to a program called Healthy Steps that we have at Montefiore, which co-locates a pediatric psychologist into the primary care setting if the child is between a newborn up to age 5, or we could refer to behavioral health if that was indicated, or if one of the if it was indicated that someone needed help with the stress of poverty and social needs, we had a community health worker and a social worker on site that we could refer to. So almost getting to the end, but wanted to ask this last poll question. True or false? The CDC 10-item ACEs questionnaire covers the full range of all ACEs that individuals may experience. I'll give you a few seconds to respond. Very good. So that's correct. The answer is indeed false. And, I sort of mentioned this at the outset of my presentation, so I may have given the answer away early. But, again, there's concern that that original 10-item screener really doesn't fully capture sort of the unique lived experiences of communities of color, of other, communities. And so the CDC actually recently updated that original ACEs triangle that I shared at the beginning of the talk when I defined ACEs, and include sort of social conditions, the local context, historical traumas, what they term generational embodiment. Things like systemic and structural racism, for example. Children of color in particular may experience these unique sort of stressors that cause downstream effects that the original ACEs questionnaire doesn't query about. Higher rates of concentrated poverty are experienced also by people of color. The ACEs does ask a question about poverty and material hardship, so that's there. But I think it's important to consider expanding ACEs screening, and there's just a lot of discussion and some studies coming out supporting this. So some expanded sort of ACE categories that people have raised are the death of a parent. I mentioned that when I introduced that large study done in children. That's actually not in the original ACEs questionnaire. That was a new question that was asked in the National Survey of Children's Health that asked a bunch of other sort of traditional ACEs questions, but included this one. Bullying, a history of community violence that wasn't included in the original ACEs questionnaire. It asked about domestic violence, but not community violence. And then racial and ethnic discrimination. That's also sort of a new category that the scientific community, is pushing for an addition to. There's still a lot that we don't know about ACEs screenings. One is kind of how do providers feel about doing this? Anecdotally, I can sort of share with you that when we were rolling out screening at Montefiore, there was just a lot of concern among providers that if we ask these questions, we're opening up Pandora's box and we don't really quite know how to deal with, we may not know how to deal with some of the answers, the responses that we get. There was a study conducted in 2016 that surveyed pediatricians nationally and found that only 4% of pediatricians usually ask about all ACEs. 32% did not ask about any. It's also important to really consider how best to deliver the screen. You want to minimize stigma and underreporting. Do you give the screen to someone as they nurses station and they're in triage and they're kind of alone? These are important questions to consider. And then of course, the accuracy of these screening tools is still a big unknown, their sensitivity, specificity, their predictive value. So further research is really needed examining the benefits of universally screening for ACEs in primary care settings. I just want to end my talk with trauma-informed care and interventions to build resilience. And, we know that we can actually sort of protect against toxic stress by identifying things that are resilience promoting, these buffers, things like stable, responsive relationships, environments that are really health promoting, that help to prevent the downstream effects of adversity and toxic stress. And so, if you're a clinician in the audience and you're seeing, and you're screening for ACEs and you're seeing someone who has ACEs and are also experiencing concurrent trauma symptoms, we know that trauma-focused cognitive behavioral therapy, that behavioral health particularly integrating it into primary care to give folks the best access to behavioral health, and stress reduction techniques, mindfulness, meditation, yoga, those things the science is starting to show are beneficial for someone who has been exposed to trauma and is currently experiencing trauma symptoms. If you are screening a parent for their own ACEs and they're positive and they're also experiencing stress related to parenting, programs like Healthy Steps, like Triple P, nurse family partnerships, those have been shown to be effective at, addressing parenting stress among folks who screen positive for adversity. If you have a child or an adult who screens positive for ACEs, experiencing concurrent trauma or mental health symptoms, and also may have a physical health condition, there's a program called Health Homes it's for children enrolled in Medicaid and also adults who are Medicaid enrolled. You get assigned a care manager to help coordinate care and services, and also helps to address other social needs, social determinants of health. And, ACEs and social needs kind of go hand in hand in many populations. And so community health workers, patient navigators, that's been shown in the literature to have positive effects in terms of ensuring engagement in mental health, physical health, and other social services, and also closing communication loops. I just quickly wanted to talk about trauma-informed care. And it's, a term that we're hearing more and more about as the science behind ACEs sort of gets widely disseminated. There are 4 R's associated with trauma-informed care. So really, if you're planning to implement ACEs screening at your institution, or you really just want to create a culture of making people aware of the science behind ACEs and downstream effects, just recognizing that it's important to educate folks or make them realize the widespread impact of trauma and understand potential paths for recovery. So at Montefiore, we created a whole sort of ACEs science curriculum that we shared with not only the docs and the nurses, but security guard staff, front desk staff. Everyone had an opportunity to take the courses that we developed around ACEs. Teaching people, especially frontline workers, how to recognize the signs and symptoms of trauma in clients and in families and staff. Responding by fully integrating knowledge about trauma into policies, procedures, and practices. And finally, taking care to resist re-traumatization. Awareness of exposure to ACEs, or awareness of someone's positive ACE screen, for example, might help you approach how you conduct a physical exam differently. Really being mindful of resisting the risk of re-traumatizing someone based on sort of how you deliver care. I'm going to move through this. It's sort of a repeat of what I said in the previous slide, but one thing to note is that when in the process of becoming trauma informed and developing policies and protocols to systematically identify trauma in patients, you really want to ensure that you have services and supports in place to assist those children and those families, those adults with identified needs. If those supports aren't in place, you want to think long and hard about whether it's appropriate to implement ACEs screening in whatever setting you work in. Just to sort of summarize, at the population level, ACEs data can really help you enable better targeting of resources to high-risk patients. So at the time I left Montefiore in 2019, we had screened over 16,000 unique patients for ACEs. And what that data was starting to help us do was to help track engagement in care. So for example, are those folks that score high on their ACEs screen more likely to miss appointments? Do we need to sort of tailor interventions around optimizing their engagement for that population? Are they more likely to use the healthcare system in suboptimal ways? It allowed us to track their risk for developing more severe health symptoms and diseases. Building a culture of trauma-informed care. So not only educating patient and staff about trauma and ACEs, but also recognizing that, when you work with traumatized families, it's really hard not to internalize some of what you're seeing and experiencing. And there is, this term vicarious trauma. So, the trauma that you yourself, traumatic stress that you yourself experience just by sort of being a support for someone who themselves has trauma symptoms. You really want to put in place interventions to help staff kind of deal with what they might be experiencing as a result of working with traumatized populations. Building, and then, using community level ACEs data to bring stakeholders together to forge formal partnerships. So in different states across this country, they've recognized sort of the public health emergency behind ACEs and have actually forged cross-sector collaborations that involve juvenile justice, the police, mental health, physical health, and hospital systems, all kind of coming together. Parents, patients, they sort of have these advisory boards all coming together to sort of discuss how, we think about collecting ACEs data at the community level in ways that are sort of sensitive to the needs and the unique experiences of that community. So that's sort of happening more and more. We know that what the protective factors are that really help to build resilience. So having supportive family environment and social networks, concrete support for basic needs, parenting skills, really developing, nurturing parenting skills, ensuring that families have access to employment, education, and adequate housing, and really optimizing access to healthcare and social services. All of those things have actually been shown in studies to decrease stress and traumatic stress, and are, known protective factors. So we know sort of what works. Really developing a systems approach to building resilience, partnering with schools and community-based organizations, integrating mental health into primary care, and really optimizing coordinated care and what's often called wraparound care. So wrapping supports and services around families who either, have high ACEs and are experiencing concurrent traumatic stress or other social determinants of health. All of those things are critical to truly start being able to start to move the needle around preventing some of those negative health consequences of adversity. I just wanted to end by introducing my new role and kind of what my practice is doing to address adversity, traumatic stress, and its downstream negative consequences. So, we know that integrating mental health into primary care has so many benefits, right? But one of the challenges is that for families who have a lot of social needs, we're still in the health setting having to refer them out to outside agencies. And that's really burdensome for those parents, those adults who have to sort of try to address their own physical health issues, mental health issues, and also make appointments and, you know, try to sort of engage in other services outside of healthcare. And so what we do at Strong Children Wellness is that we bring primary care into mental health and social service agencies. And so that really allows us to provide integrated, coordinated support, for ACEs, social needs, mental health, and physical health. And I'll end there. I went a little bit longer than I had planned to, but happy to take any questions.
Thank you so much. I do have one question thus far. And remember, everybody, you can still type some questions into the question and answer box. And the question I have here is, what percentage of parents actually completed the questionnaire?
Yeah, so everyone completed, almost everyone. I think we had like a 93% completion rate when we screened. Although they completed it, the responses weren't always sort of reflective of their true experience. So there was a lot of underreporting. And, you know, I knew that as a clinician who took care of some of these families. You get to know them over time. You know that there's a family who probably has an ACE score of 8 and they were reporting a 0. And, you know, it goes back to sort of what I mentioned about kind of the stigma of these questions, that when parents see some of this, you know, it's triggering, or they're concerned about why you're asking. You know, some people may be afraid that you might use the responses against them or their family. And so we, at the time that I left, we're really starting to do a deep dive into what the reasons were for underreporting. And I think that deep dive is still happening. We don't quite know. But you know, it's for other institutions that have done this, they've reported that same challenge of people are completing it, but there's a lot of underreporting.
And I have another question that just came in. Are there specific interventions you have used with parents who have high ACEs? Is there any research that shows how intervening with the parents decreases the child's risk?
Yes, so I mentioned Healthy Steps. Healthy Steps is an intervention that co-locates a PhD level pediatric child psychologist who is well trained on not only kind of dealing with early childhood developmental and social emotional difficulties, but also parenting stress. Putting them into pediatric practice and giving parents access to that specialist has been shown in a couple of studies to actually be really protective. So one study showed that specifically for parents who had higher ACE scores, Healthy Steps really helped to prevent poor child development downstream. You know, there's other emerging science coming out about its effectiveness at reducing parenting stress and sort of really empowering the parent despite their exposure to adversity to be the best parent they can be. So Healthy Steps. The Triple P program is another. I don't know that they've specifically looked at, you know, parents with ACEs, but just in general, Triple P is a parenting program for parents of young children that has also been shown to reduce parenting stress.
While I wait to see if there are any more audience questions, something that came to my mind is the COVID-19 pandemic and ACE. And what are your comments on that?
So I would say yes, that's a really excellent point. There's actually a study that came out from the CDC, I think back in July, that said that 25% of people that they surveyed reported experiencing symptoms of trauma during COVID specifically. Whether it's, you know, sort of the fear of kind of the pandemic and what that can do versus what the pandemic has wrought, which is sort of unemployment, you know, sort of the downstream effects of poverty and the stress associated with that. We're still teasing that out, but I think COVID has for sure just laid bare you know, some real societal inequities, has worsened, you know, poverty on many levels and poverty related stress. And people are definitely feeling that. And I'm seeing that in my own practice. So I would include it as an adverse experience for sure.
Okay. So I don't see any more questions at the present time. So Dr. Brown, thank you so much for that excellent presentation.
Thank
Great
you.
information. Absolutely. To the audience, you'll be receiving a short survey after the session, and we would really appreciate your feedback. And on behalf of Care Compass Network and the Regional Trauma Informed Care Network, thank you so much for joining us today. And have a great rest of the day.
Thank you.